my dear chairpersons, and my dear colleagues on the floor, Professor Dr. Sraq, thank you for the invitation. I'm really honored to be here today with all these professors on the stage with me. It's really an honor. Our title of the topic today is Toward a Healthy Liver and Gastrointestinal Tract. William Allister, or Sir William Allister, he's the father of the modern medicine. He had a very nice quote, which is one of the first duties of the physician is to educate the masses, not to take medicine. And I think this is the function of the therapeutic nutrition. You must educate the people what to eat before they prescribe them medicine. I'm really honored to have with me Professor Dr. Ahmed Shawqi, Ain Shams University, Professor Dr. Hanan Nuh, she is online, Alexandria University, Professor Dr. Baha Abbas, Military Medical Academy, Professor Dr. Fatma Murad, Al-Azhar University. Okay. Professor Dr. Wissam Ibrahim Ain Shams, and Professor Daria, I hope she is online with us. And I'm really honored today to be with Professor Dr. Forbes on the same session, and I hope, looking forward to see her in Egypt, not only online. The gut serves many essential roles in sustaining and protecting the overall health and wellness of our bodies, starting with the intake and absorption of nutrients and water, the digestive process that provides building blocks the body needs to live, to function, and to stay healthy. While the gastrointestinal tract ingests, digests, and absorbs nutrients, the liver transforms nutrients, synthesizes plasma proteins, and detoxifies bacteria and toxins absorbed from the gut. It is therefore not surprising that the gastrointestinal tract and the hepatic disease have a major impact on the nutritional status of the individual. And Dr. Gerard Millian, he is a professor of internal medicine, board certificate gastroenterology and nutrition, Johns Hopkins, and he has a very, very nice book on the gastrointestinal and liver disease, nutrition referring. I hope everyone of the gastroenterologists have this book. Digestive disorders are among the most common problems in the healthcare. Between 60 and 70 million people are affected by all digestive disease. Dietary habits and specific food types can play an important role in the onset, treatment, and prevention of many GI disorder. Nutrition therapies is integral in the prevention and treatments of malnutrition and deficiencies that can develop from gastrointestinal tract disease. And diet and lifestyle modification can improve a patient's quality of life by elevating GIT symptoms and decrease the number of healthcare visits and costs associated with GIT diseases. So 100% right, a healthy liver and GIT is a gate of a healthy life. I'm really honored again to have for the second time within the 6 months in one session me with Professor Dr. Alistair Forbes, Tartu University, Estonia, Professor of Internal Medicine. Welcome, sir. Are you here us? Professor Forbes? In the connection, you see Professor Forbes for attendees? Online? Can he hear us? Can he hear us, Professor Forbes? عنده هو connection problem. Okay. I think Dr. Forbes have some sort of connection problem. I will jump to my presentation about how to lose weight and keep your liver healthy until the connection be resumed with Professor Forbes. A journey to a healthy liver while losing weight. The story I will tell you, it's a very common story. A person with a BMI over 30, either presence or absence of comorbidities. He advised for a special diet, or he advised for a gastric balloon or any type of bariatric surgery, either restrictive or malabsorptive one. Within insisting of their patients on rapid weight loss from the patients, and the doctor want to show he is the only one can do this for the patients. The problem اللي بتحصل اللي حضراتكم هتشوفوها 2-3 months after any modality applied with weight loss of more than 15 to 20 kilogram, the patients came to us with elevated liver enzymes, and I think this is a very common problem the hepatologists face it. The problem is, as we have fat in all our body, the fat also deposited in the liver, and not only the liver have a non-alcoholic liver disease, which is high prevalent with the diabetic and obese patients, but also when you are fortunate and you have not a fatty liver with overweight, when you go on for a rapid weight loss, you will devastate the liver and you will get a fatty liver disease to yourself. In 2018, the practice guidelines for the American Association of the Study of Liver Disease include the following recommendation regarding treatment of non-alcoholic fatty liver disease. And she stated the physiological benefits of 10% weight loss, of the drop of the diabetes, hemoglobin A1C, LDL, the rise of HDL, the drop of triglycerides. And the most important, she stated that 3 to 5% weight loss improve hepatic steatosis, and 10% almost cure from simple steatosis and improve necroinflammation, and even can regret one stage of fibrosis back. But there is a hazard of rapid weight loss. A lot of hazards, from gallstones, bone loss, high uric acid, loss of muscle tissue, loss of water, electrolytes, and the most important is a hazard of rapid weight loss is by itself the non-alcoholic fatty liver disease. So if you have fortunately passed the overweight and you didn't have a fatty liver and you still have a normal liver, you will get it when you make rapid weight loss. Fatty liver has reported in 70 to 80% of obese individuals. Obesity have reported in 70 and 100% of cases of NASH. Among patients with hyperlipidemia, at least 65 with hypertriglyceridemia and 35 with hypercholesterolemia have fatty liver. So the problem is always it. Either you deliver a lot of fat to the liver or deliver a lot of carbs to the liver beyond the capability to deal with, so it will accumulate in the liver cell, or you have a problem in the mitochondria in the liver, so it cannot oxidize the fat. You have a problem in mitochondrial fat oxidation, or the problem is in exporting of fat of the liver impairment. So it's like a factory, the input in excess for the capability of the machine and the factory to deal with, or there is a problem in the machine inside the factory to deal with, or there is a problem in the cars that will take the already products of the factory outside, so will accumulating inside the liver cells. Fatty liver, the same pathology occur with rapid weight loss, because fat passing to the liver, it's either from the chylomicrons in the food in large amount of fat, or when you wash your fat cell with a rapid weight loss, they will overload the liver like you eat a lot of fat. Both will trigger the inflammatory cascade in the liver and ending in an inflammation and fibrosis. So a rapid weight loss with a gush of a lot of fat to the liver, it's mimic the eating a lot of fat and you are overweight and obese. Both entering the liver in a late of a chronic stage of a chronic stress, high insulin, disturbance in the carbohydrate binding protein and sorbitol binding protein, and disturbance burden with on the mitochondria. She cannot oxidize the fat, and so the factory cannot make the products and make them out of the liver. The problem with a fatty liver is multifactorial. adiponectin, genotype PNP, intestinal resistance, and insulin resistance and microbiome. But the important with the rapid weight loss is the free fatty acid delivered a lot, is the endoplasmic stress putting in the liver, and the oxidative stress a very humongous, so make deterioration of the condition. Again, Sir William Allister, the father of the modern medicine, he tells us medicine is the science of uncertainty and an art of probability. Which one putting the liver in that stage? Is the lot of fat in the food, or the delivery from weight loss? Is the mitochondria affected or not? Is the factory cannot get the triglycerides or not? It's a lot of probability. The effect of a rapid weight loss, it is published since 1998 with the commitment on more than one publication that higher fasting glucose and hypertriglyceridemia is the main cause of fatty liver, and both gastroplasty weight loss reduce liver steatosis but seem to increase the incidence of inflammatory lobular hepatitis. And they define the rapid weight loss with a definition of 19 kilograms within 3 months. Another study with the research suggests that a rapid mobilization of intra and extrahepatic store may represent a hepatotoxic effect and could explain the observed steatohepatitis that occur with rapid weight loss. So, to lose weight healthy, you have to identify proper assessment to your liver before you are put on a program. Rate of weight loss must be identified clearly not to harm your liver, and the types of food intake. As simple as you not need a liver biopsy, you not need a fibroscan, it's essential, but as simple as with the sonar, you can grade the steatosis and it's perfectly correlated with the biopsy. And these are the results of our works here in Egypt on the Google. I mean, you map the correlation between the ultrasound and the liver steatosis in biopsy. This is our table, the only one on Google. You can get by ultrasound how the liver muchly affected, and you can by that make a proper management protocol for weight loss of that patient's. Healthy rate of weight loss, the maximum amount of body fat a healthy person can lose is about 1.3 to 1.8 per week. Typically, only obese are likely to able to lose this amount of fat. By comparison, the maximum amount, meaning in any female in an average weight of 65 to 70, the maximum healthy weight she can lose is the 0.7 per week, because the body is not designed to shed weight, it is designed to survive. This is why it won't lose excessive amount of fat in a short period of time. The National Health Lung Institution and National Institution of Diabetes and Kidney Disease 2006 put the guidelines for weight loss. Okay. For weight loss in the presence of non-alcoholic fatty liver disease, weight loss should proceed at a rate of 0.5 to 0.9 kilogram per week, not exceeding 1 kilogram, and monitoring of liver dysfunction by checking liver function tests once a month, especially when the weight loss is rapid and they identify a rapid weight loss of more than 1.2 kilogram per week. So it did not reach even 5 kilogram per month. Dietary recommendation: low fat diet, low saturated fat, and never trans fat really. Modulate the carbohydrates by low glycemic index food, low fructose diet, the Mediterranean type of diet, improve liver mitochondrial oxidation of fat, and I will tell you how to prove it. Support your microbiome and good hydration. What are the types of fat we know? We have the unsaturated fat. This is the healthy one, which is an absolutely healthy in any amounts, any nuts, any seeds, and the fish. We have the saturated fat, the beef, the chicken, the butter, the cheese, and coconut oil. Now they are okay in a small amounts, but they must be included in the food. And the trans fat, which is completely, you must skip it, the processed food, the hydrogenated vegetable oils, the fried foods. A lot in the world changed since the recent 3 years because we see that the patients coming after they made the bypass operations from any European country, especially UK and Germany, and they tell them, please, you must eat the goat meat or the sheep meat. And when they come here to Egypt, they tell us, wow, I will eat this and not fear for my cardiovascular insult. Yes, they have a saturated fat, and you must put a saturated fat in your food, but with a percentage. So shifting from saturated fatty acid-based to food-based dietary guidelines for cardiovascular in 2020, the previous advice restricts saturated fat, and the new advice should emphasize food-based strategies that translate for the public into understandable, consistent, and robust recommendation for healthy dietary fat. So I must eat saturated fat? Yes, you must eat saturated fat in whole milk products, the butter, but in a very small amount. We have the benefits. We need it for the liver, and we need it for a healthy life. Please see with me. This is the amount of saturated fat on total fat on the meat. 100 grams contain 7 total fat and 2.1 saturated fat. The eggs have 10 full fat and 3.1 saturated fat, and your upper limit of a healthy fat intake, you must take a saturated fat. Not only it's luxury, you must take it up to 20 grams per day. Why? Because the saturated fat have something called conjugated linoleic acid. Conjugated linoleic acid is 2 types. The one is healthy, which is the natural conjugated linoleic acid, improving insulin resistance, anti-inflammatory, anti-atherogenic, anti-carcinogenic, anti-diabetic, immune modulation. And at the same time, omega-6 can cause milk fat depression, can cause insulin resistance, can cause irritation of the intestine. And that picture made us think a lot of times up to 11 months before we conduct our works in 2080. What is the difference between those types of conjugated linoleic acid and which one is healthy, and from which type of food I will take the healthy one? And we presented it. I was honored to present it in Indo, the most popular and the first one endocrine conference worldwide in Chicago, USA. And even our work published in endocrine review with the biggest impact factor 15.5. And we stated that have lists here are some of the functional diet rich in conjugated linoleic acid, which improve insulin resistance, which is an antioxidant, and it is present in the full fat milk, the butter, the goat, and the sheep meat. And you must take at least 1 to 2 servings per day. Yes, when you're losing weight and when you are healthy. This is the conjugated linoleic acid were present, and the artificial conjugated linoleic acid in the capsule or in the oil are artificial, are in danger to your health. L-carnitine is very important because it increases mitochondrial fat oxidation. And again, the best source of L-carnitine is the beef, is the chicken, is the sheep, and not the vegetables. Not the tomato. You must take it per day. A full saturated fat up to 20 grams. It's healthy, not forbidden at all. Mitochondria, regular intake of probiotic and prebiotic food is important, like the lactobacillus and the bifido. Particularly, we have only product in Egypt containing the bifidobacteria, and the other type of yogurt in Egypt are nil of the probiotic. The bacteria important, and the type of bacteria important, and the starter you put important is the fiber content of food, the prebiotic, and our traditional Egyptian bread is the best source of that fiber, and the fava bean is a very good source of that fiber. Certain dietary sugars, particularly fructose, induce endoplasmic reticulum stress on the liver, and this is aggravate the condition. If you didn't have a fatty liver and you lose weight with a lot of fructose in your diet, you will get a fatty liver. In patients with non-alcoholic fatty liver, the consumption of fructose per day was associated with more extensive fibrosis. You must take a low glycemic index food, better for your blood sugar, away from any processed food containing high fructose content. The fructose in vegetables and fruits are safe due to the fibers with them, but when they are in processed food, they are very dangerous. The American Association for the Study of Liver Disease 2080 diet is recommended and weight loss of goal of 1.2 pounds per week, not exceeding 1 kilogram. A combination of reduced caloric diet and exercise is healthy to your liver, not only to your heart. And the University of Michigan Metabolic Fitness Program in 2090 stated that the Mediterranean type of food is the best one to get healthy and the best program associated with daily exercise 20 minutes to keep your liver normal. The Mediterranean type of food, that's the different types we stated before, you must put it in your food, and it's coming from our traditional Egyptian food. We are the first to put the Mediterranean type of food. And please sleep well. Deprivation of sleep not make you like this, but it's deprivate your microbiota, increase the interleukin activity in the liver and the fibrosis, and exercise well. Exercise is good with improvement of your microbiota, important for your healthy liver, and not take a lot of antibiotics. A lot of antibiotics suppress your microbiota and aggravate the dysbiosis in the liver and the gut dysbiosis. Please, at the end, take care of your liver by slow weight loss. Mediterranean type of food is the perfect solution. Exercise regularly, sleep well, please, and limit prescription of antibiotic except the recommended. Please take care of your liver. And online, they are my books for nutrition. You can get them online free. Thank you so much. Yes, Dr. Shawi. Yes.
Thank you.
Thank you, sir.
I want to highlight some point.
Yes.
Your speech is that to NASH or NAFL.
Professor Forbes, again.
Hi. معلش مش عارف.
Yes.
Thank you for your elegant lecture.
Thank you, sir.
I guess that you concentrate on NAFL and NASH.
Yes.
So loss of body weight is very required in this condition to prevent progression of disease.
Sure.
But on the other side, I want to highlight liver cirrhosis.
Yes.
We need some sort of nutrition in liver cirrhotic patient.
Definitely.
The cirrhotic patient has a paradox of two things. Increased body weight due to salt and water retention.
Yes.
And in spite of sarcopenia, loss of muscle.
And the flash from the liver cells.
Defective nutrition.
Sure.
All of us are concentrating on restricting animal proteins for this patient, but nowadays all the literature say that we can give them
recommend the protein,
but in the required amount, 1 to 2 grams per kilogram body weight.
Sure.
And we can replace them with plant proteins.
Definitely.
We must differentiate between frailty, weakness, sarcopenia.
Okay.
Weakness is the disease due to muscle affection. Frailty, normal muscle, but he cannot do his effort.
Yes.
Nutrition for this patient, did you recommend some way to give nutrition in 5 minutes or 2 minutes for cirrhotic patient with ascites?
It's need a complete presentation. It will take more than 1 hour. Nutrition in sarcopenic patients with liver cirrhosis.
Broad lines.
Okay. Can we? I excuse. Yes. We joined Professor Forbes, and I will answer the question after. Thank you, Professor Shawi. Professor Forbes. Hi.
Hello.
How are you? Good morning.
Do you hear me now?
I'm honored to be with you today. Sorry that I precede you in the presentation.
Not at all.
You must be the first, definitely. Okay, Professor Alistair Forbes, a professor of internal medicine, Tartu University, Estonia. Welcome, sir, and the floor is yours. Okay.
Thank you so much. You can hear me well? Yes? I hope, yeah. And I apologize, the link didn't work before, but everything seems fine now.
Share the slides, sir?
I can see you, and you can hear me, and we can see each other.
We hear you, but you start to share the slides?
Yep. Let's just see. I hope you see my slides now. Do you?
No. Yes. Okay.
Yes. Okay. So evolution in diet. Now we have had a wonderful talk from Mona, And that has actually been a very good introduction for my talk. And I think it's probably been a good thing that they've been the opposite way around. So I'm going to tell you about the history of diet and gastroenterology. And it suits Egypt because it goes back many thousands of years. But I'll also try and explain what I mean by the title. Diet has an effect on the gut. Diet has an effect on gastrointestinal disease. Diet has changed over time and will continue to change. And those changes in diet are relevant to gastroenterologists. And we'll see why as we go through the talk. Just for those of you that don't know where Tartu and Estonia are, you know where Europe is. And I'm right up here now in the north of Europe, in this little country of Estonia. And that's the hospital where I work at the top, the river in the city centre and the town hall. It's a really pretty place. So, evolution, survival of the fittest. It is reasonable to assume that human evolution would have incorporated the best responses to the foods that were available at the time. It's also logical that any food choices were made would best suit the evolving human. So the two things go together.
Professor Forbes, we only see the first slides and we cannot follow up with you.
Oh,
I have the slides with me.
okay.
I move it from here.
So it's not moving on when I move my slides.
I can move it from the cursor on my computer at the same time.
Okay, so I'm on about the 6th slide. So do you want to just go through then? So
you are on the first or which number?
No, I'm on about the 6th slide. I didn't realize that it wasn't moving because it's moving on my screen.
Can I excuse you to start again from the start and I will move the slide from here?
Try again then. So do you see my slides now?
Yeah.
Do you see the 2nd slide?
Yeah, it's fine.
And my map? No.
I will make the slideshow from my side.
Yeah, okay.
Just tell me next and okay. Now it's fine. Please back to slide number 1. Please back.
Okay, this is fine then. So I'm just showing you the Tartu in the north of Europe. So if you click again, that will show you an arrow. And the next slide is some pictures of the city. So the hospital at the top, the river in the city centre and the town hall. So a pretty place. And when travel is easier again, I hope some of you will come and visit us here. The next slide. It is reasonable to assume that human evolution incorporated the best responses to the available foods, and in turn, that food choices would best suit the evolving human. So the two things go in parallel. Next slide. And on that basis, the Paleolithic diet, the diet that was eaten in the Stone Age, should, on evolutionary criteria, be the best possible diet for us, because it's the diet that we evolved to eat and which was suited for us, and why the best surviving people chose that diet. In much the same way that we understand with animals, that we understand that the big cats are carnivores and that elephants are herbivores. They have developed evolutionarily a diet that suits them and that they suit. And there's every reason to suppose that humans would be the same. So on that basis, the Paleolithic diet should be ideal for us. Next slide. What was the Paleolithic period? It's the age defined by the use of stone tools. That's where the word comes from. And it began before Homo sapiens, in fact, about 100,000 years ago. And if you look at the genetic changes between those pre-Homo sapiens people and now, they're really quite trivial. And it's unlikely that there's anything in our genes that is different in terms of our ability to interact with our diet. Next slide. Lifestyle was initially nomadic, without any formal agriculture. As time went by, hunting weapons existed and fire was used in cooking, and cave paintings suggest that fermented foods and wine were also consumed. I'm sure that wasn't true Egypt, of course. This cave painting is from Namibia, but those they definitely look a bit intoxicated, don't they? They don't look as though they were completely sober. Next slide, then. So we don't know the relative quantities of these. We know quite a bit about what foods were consumed because of remnants of food in those ancient cave sites, but we don't know the relative quantities in any detail. But it appears that where possible, game, so hunted things like rabbits and game birds and fish were important, but otherwise there was a lot of foraging with a lot of reliance on things that could just be picked up, like fruit and eggs. Next slide.
Excuse me, Alistair.
Do you hear me okay? I'm getting the sudden
Yes.
I want to ask about the Paleolithic food, type of food. What is it?
So this is the food of that period. So the time that we're talking about, the Stone Age period, these are the things that were being eaten then. And it was place and culture specific. And fish was an important component in places where it was safe to fish. So you could imagine that in Egypt, there would be a lot of use of fish in the areas close to the Nile, close to the Mediterranean, but maybe not so much out in the desert.
Yes, meaning it's a type of food from the cave people, old cave people, eating a lot of fish from the sea and a lot of fruits from the trees. This
Exactly.
is their types of food, you mean?
Exactly, but of course dependent on what was available. And if they were in the center of Europe or the center of Africa where there was no water, then fish would not be important. And generally speaking, animal meat was more important in colder regions, but a very intermittent supply, because without farming, there were no cows or sheep or pigs that were kept. So it was just what you happened to find when you were out hunting. And it was very understandable that the evolutionary drive was to eat as much as possible whenever possible. Food was rare. And so the biological signals were all to eat as much as possible, as often as possible, recognizing that there were likely to be periods of famine. Next slide. That meant, of course, that there wasn't a great deal of complex carbohydrate other than that came from free-growing fruit and vegetables. So, for example, carrots and bananas, which grow without you needing a farmer, there was plenty of that. But otherwise, carbohydrate was not present in complex form. So not from wheat, not from rice, because those things require a degree of agriculture and cultivation. And cereals weren't introduced into the diet until about 30,000 years ago, which is a long time after most of the genetic signals had already been set. And animals, for milking, were not kept until about 10,000 years ago. So the introduction of milk and dairy foods in all its form didn't come into the diet until relatively recently. Next slide. So should we advise a Paleolithic diet? If you look at what's in it, a lot of it is very common to what Mona was just talking about in the recommendations for a healthy diet for people in general. Plenty of fruit, plenty of vegetables, not much dairy food. The main difference from current advice is the absence of cereals for complex carbohydrate, and probably because it contained rather more fish and meat. And so we need to ask the question there, would it offer any advantage over a more conventional, modern, healthy diet? And there's now quite a strong body of public opinion favoring a Paleolithic diet in the United States. And if you go into the bigger supermarkets in the United States now, you will often find a Paleolithic aisle where you can go and choose foods that would have been available for the Stone Age man. Is that a good idea? Next slide. Well, what about gastroenterology in Paleolithic times? We don't have to be particularly speculative about it. We can predict fairly precisely what the consultant gastroenterology specialist would have been seeing 100,000 years ago. The average life expectancy was under 40, often under 35. And the predominant gastrointestinal diseases will have been infections. There will have been virtually no gastrointestinal cancer, no gallstones, very little pancreatitis. Liver disease, yes, but mainly infective, so viral hepatitis. No inflammatory bowel disease. Who knows about irritable bowel syndrome? But no inflammatory bowel disease. That's very much a disease of civilization, very much a disease of the last 100, 150 years. So these people were exposed to infection and not so much to other things. We go to the next slide. And they developed folk remedies. We don't know which folk remedies were important 100,000 years ago, but we do know folk remedies that have been important 100, 200, 500 years ago. And it's likely that they haven't changed very much over that time. And they are surprisingly effective. We take an example, the pineapple, not much dealt with in the scientific literature, really until about 30 years ago. But we know now that a key part of the pineapple is bromelain. This is its highest concentration in the stem of the pineapple. It contains a proteolytic enzyme, which is very effective against many of the gut parasites. So eating pineapple is good for you. Eating pineapple is actually a mild but effective treatment for many gastrointestinal parasites. If you then do modern controlled clinical trials, you can demonstrate that it has a value in acute diarrheal illness. In mice, you can prevent and treat infective colitis. You can prevent infective diarrhea in piglets. And in a small study, it's even been used in resistant ulcerative colitis in man. So pineapple, a treatment that was available 100,000 years ago, is an effective treatment. And then as recently as 2001, this was the front cover of Gastroenterology, green bananas. And green bananas also were part of folk remedies, so traditional treatments offered by the village grandmother. Now we know green banana pectin, also effective in acute childhood diarrhea. Controlled clinical trial, at 3 days, 55% resolution compared to 15% in the control group. It needs about 250 grams of green banana per kilogram of feed. So it means eating quite a lot of green bananas, but it works and was available. We have to be aware, though, that as soon as we start talking about dietary interventions and things that are available to the lay public, we also run the risk of crazy people. And this was a story that was publicized in the British media 5 or 6 years ago. The suggestion that 6 or more bananas could kill you. Now, of course, it's nonsense, but that didn't stop it getting front page treatment in the newspapers and potentially did quite a lot of damage to the good messages about the benefits of eating fruit and vegetables. So we have to be very careful that although in general, the messages that come from traditional folk remedies and folk treatments are wise, there are also some crazinesses that need to be dispelled. So, Paleolithic gastrointestinal therapy. Folk remedies, surprisingly effective. Green bananas, pineapple, I've told you. And later, when there was agriculture and we were able to include rice, we can demonstrate that rice water is more effective than water with glucose for oral rehydration solution. And with the possible exception of vaccination, oral rehydration solution has been the most important therapy in the history of medicine in terms of saving lives, certainly saving children's lives. We know that oral rehydration solution is a fantastically important intervention, but we now know that rice-based oral rehydration solution is better than glucose-based oral rehydration tools. And these are just 2 example papers. There are plenty of others. This Cochrane analysis included 34 different trials with over 4,000 patients. If you use rice as the carbohydrate using a complex, less osmolar carbohydrate, the effect is better. Less need for intravenous support, shorter duration of diarrhea. So the change from the Paleolithic to the pre-industrial period, there were changes mainly in the adoption of farm foods, and I've talked about the importance of the cereals there, rice, wheat, and so on. And food availability over that 100,000 years gradually became more secure and safer. You were less likely to be eaten by a lion while you were looking for your food. Cereals became staples across the world, and where it was possible and where animals were kept for milk, dairy foods became important, much less so in Asia than in Europe and Africa, but certainly in Europe, dairy foods became quite an important component of the diet. Meat, generally speaking, remained sporadic. It was sporadic now, not only because the animals were difficult to capture, but also because they were expensive. And during those several tens of thousands of years, life expectancy improved by a decade or so. So instead of dying at 35, people were dying at 45. The maxim of maximal eating, however, remained, with very strong genetic factors that I've talked about, but also a number of very important social drivers. And we still see this in many parts of the world now. You'll recognize this thin man who was Henry VIII, King of England in the 16th century. Now, he wasn't that size when he became king, but he grew, and it was a demonstration of his importance. He could be fat because he was the king. And that demonstration of power through size has only quite recently begun to be lost. And it's still true that every American president, bar one, has been the taller of the 2 competitors in the election. That's obviously not the only reason, but it's an indication of how shape and size can be important in our perceptions of people. So, infective disease is still most prevalent. We're now in the 16th, 17th century, we're seeing peptic ulcer. We're beginning to see cancers evolving and appearing as the population ages. There's beginning to be some alcohol-related disease, and some of the diseases of civilization are beginning to appear. Still no inflammatory bowel disease, very little diverticular disease, very little in the way of gallstones. But then we get the Industrial Revolution. And suddenly, in the middle of the 19th and towards the beginning of the 20th century, we get very, very rapid changes. Revolution much more than evolution. Huge improvements in food safety, introduction of numerous processed foods, which largely means that they're foods that last, that they don't go off, that they can be kept. You've heard already about the perils, particularly of high fructose foods and the high fructose foods that come without the vegetables and fruits that they're meant to belong with. High fructose corn syrup is possibly the single most important component of the obesity epidemic in the world. So we see now much more availability, much lower cost. Food production is much more efficient. People are healthier in general, and life expectancy improves by another decade or so. But the maximal eating remains. We're now seeing infective disease, but managed better. Peptic ulcer almost eliminated now that we know about H. pylori. We can now control and eliminate a lot of viral hepatitis. We're seeing a great deal more cancer because the population is aging, or at least with colorectal cancer, we can offset that by successful screening programs. And we see all the diseases of civilization. And even in Egypt, there's more alcohol-related disease. So even in countries where alcohol isn't a normal part of social interaction, alcohol-related disease becomes an important factor too. Just a word about inflammatory bowel disease. Not really recorded convincingly before 1900. There are a few case reports from the last years of the 19th century, but nothing that's absolutely convincing. Louis XIII in France had intestinal strictures and fistulae, and I wanted to believe for a long time that he had Crohn's disease, but I think he probably had TB. And what we saw with inflammatory bowel disease is that it appeared in Northern Europe and spread south and east. And it's clear that it's not determined by genetic factors. The genes in Northern Europe are not very different from the genes in Southern Europe. And indeed, where there are genetic differences, they're much more local than that. So there are big differences in the genetic profile for inflammatory bowel disease between England and Scotland, which are only a matter of 200 kilometers apart from each other. It isn't explained by smoking. It might perhaps be partly influenced by refrigeration and probably by diet. So we go to the next slide. There is a strong correlation between family ownership of a fridge and the risk of inflammatory bowel disease. That's no longer true because now everyone has a fridge. But in the 1950s, when having a fridge was relatively unusual, having a fridge, having hot running water, having an inside toilet, and no farm animals in the house had strong correlations with inflammatory bowel disease. So if you had goats and sheep in your house, you had to walk down the yard to get to the toilet, you had to boil a kettle to get hot water, and you had no fridge, then you almost certainly wouldn't get ulcerative colitis or Crohn's disease. You might die of a few other things, but you wouldn't get inflammatory bowel disease. Now, to say it's cause and effect is obviously a big step, but there is a clear socioeconomic association. And I think that part of the problem may be organisms that are preserved at fridge temperature without destroying the food. So if you don't have a fridge, your perishable food quite quickly becomes inedible. You look at the strawberry that's gone moldy and you say, I'm not eating that. But perhaps the organisms like Listeria that survive in the fridge and don't make the food go visibly moldy might be important. You heard a little bit also about the importance of essential fats. And we see in inflammatory bowel disease that the patients who develop inflammatory bowel disease beforehand have a higher intake of non-marine fats, a higher intake of sugar, and a lower intake of fruit and vegetables. And those are probably important factors as well. And consistently, however you define the Mediterranean diet, it seems to be helpful, protective, and at times therapeutic. So, what's the prognosis? We've heard about what's happened historically over a very long period of time, and we see that things now can change much more quickly, and changes that may be to our detriment from a genetic point of view. What's the prognosis? Well, what can we expect the interaction between diet and gastroenterology in the future? We can expect a major continuing dominance of diet-related obesity. We can expect continuing problems with alcohol excess, and we can expect that all the gastrointestinal cancers will remain for a good long time yet, even with effective screening programs. And at the moment, we have no effective screening programs for pancreatic cancer or the biliary cancers. We can expect lots more trouble with metabolic syndromes, including the various forms of non-alcoholic liver disease. We can expect alcoholic liver and pancreatic disease, and all of these form part of the bigger picture of diet and disease. And I haven't yet mentioned the microbiome. It is very likely that has been a driver in the emergence of inflammatory bowel disease. It is looking very likely that prebiotics are important and that probiotics can be used usefully as well. What's been rather neglected is the importance of fermented foods. And in many food cultures around the world, fermented foods are quite important. We know that prebiotics can be therapeutic. They can prevent infectious diarrhea, and they can prevent the hyperbilirubinemia of neonates. We know that probiotics can prevent and treat travelers' diarrhea. We know that they can prevent antibiotic-associated diarrhea. And in comparisons in maintenance of ulcerative colitis, the careful choice of probiotics can give you maintenance as good as the 5-aminosalicylates in maintenance therapy. Then we've got these fermented foods. There's quite a range of them, and they're different sorts of foods in different cultures. So sauerkraut, pickled cabbage in Germany, kimchi, very, very important in the Korean diet, blue cheese, mainly of interest in France, Italy, and the Central European countries. Beer, of course, we don't talk about in Cairo, and an increasing portfolio of health benefits attached to these, mostly in terms of protection from gastrointestinal infection, but also in terms of long-term cardiovascular benefit. So we can summarize that from an evolutionary point of view, we have now chosen a diet that doesn't suit our genes. That might seem completely crazy, but perhaps isn't, because evolution was relevant to survival to reproductive age. And as one example, cancer is irrelevant to reproduction because you mostly don't get cancer until you've already got your children. So perhaps the Paleolithic diet and the Paleolithic approach is not as relevant as all that, but we can still learn from it. We can learn the value of folk remedies. We can learn the value of pineapples and green bananas and yogurt and kimchi and using rice water rather than glucose in our oral rehydration solution. But I finish by warning you, whatever you do, don't eat more than 6 bananas. And with that, I say thank you very much, and I'm very happy to answer any questions.
Thank you so much, Professor Forbes. You really took us in a journey of nutrition, an interesting journey of nutrition from the ancient Paleolithic type, and even I just know that type of ancient history from you. You teach us a lot today. Thank you. And I think it's almost the same native culture of the Egyptian, ancient Egyptian and the Paleolithic and the Asian one, the fish from the sea, the fruits and the vegetables from the trees. And this is the most healthy one. Thank you, sir, again. And I will leave the microphone to Professor Abbas. He wants to commence on your talk.
Hi, Alistair. Thank you very much for this elegant talk. Actually, first time to hear this evolution of nutrition from the Paleolithic period till now, which made our life difficult. This evolution, yeah.
I think not to be taken too serious.
Life expectancy was just less than 40 at that time. So is that due to other causes than nutrition, or?
No, they were all eaten by lions and tigers. Please don't take my talk too seriously, because there are many extrapolations. I've tried to indicate what is factually true and what is supported by controlled trials. But it's more a question of trying to encourage people to look widely and not to assume that the things that we were told at medical school were necessarily correct, and to have an open mind and to look carefully at what we're doing. One of the problems always with nutrition is it's impossible to do true placebo-controlled trials, and it's also impossible to do any sort of trial that's long enough to be likely to show the true outcome. We need to do placebo-controlled trials that last 20 years to be sure what a dietary intervention does. And we can't do that. Firstly, you can't do the placebo because you have to eat. And secondly, you can't expect anyone to stay in a trial for 10 years, let alone 20 or 30 years. So we're always in a problem with that. We're always faced with the problem of changing the diet. You increase one thing and you decrease another. And the effect might be cancelled out by those two changes or might be exaggerated by reduction of one and addition of another. So I think you use my thoughts as a little bit of light relief. You've had some very serious presentations earlier today and yesterday, I know. Use my talk as a stimulus for thinking, for discussing. And as Mona said, the Egyptian diet actually traditionally has been a very close match to what we think best diet should consist of. And that's something that shouldn't be forgotten. It's very interesting to look at, for example, the Japanese experience. There are a lot of diseases now in Japan that are frequent, that were very rare until the middle of the last century. And although they have gained in terms of life expectancy, they have also gained in terms of less gastric cancer than they used to have, but they now have a whole range of conditions that they never saw before. And we need to look at the very rapid westernization of the Japanese diet as to why that happened. And that's something that Egypt is obviously vulnerable to as well. And it would be a great shame if the possible knowledge that could be obtained from careful analysis of what has been eaten in Egypt is lost with a change moving towards the McDonaldization of diets around the world.
Okay, thank you. I think you agree that obesity and alcohol are the main risk factors for more.
Well, there isn't any alcohol intake in Egypt, is there? I thought you were a good Muslim country. No alcohol.
Okay, and your folk remedies appears that the same as ours. So do you recommend back to this folk remedies in our treatment or not?
I think we should keep our eyes open and not make assumptions based on inadequate information. And I think we should remember how easy it was to be rude to the grandmother that said to the small child who had diarrhea, "You must have green bananas." And he said, "Don't be ridiculous, it's stupid. This is an old wives' tale. We shouldn't be taking that seriously." And then you do the science and you, actually, green bananas are good. And I think there are lots of things in diet like that. Kimchi in Korea is another good example there, that it's a very important part of their diet culturally, but it may be important from a health point of view as well. And we should explore that. We should look at how it's having the effects that it may be having. And you could say exactly the same for key parts of the Egyptian diet and the importance of all the different cereal products and the way that they're used. It's different, and that may be important and valuable.
Okay, thank you. Any other questions? Professor Ali Gaballa, Professor of Internal Medicine and Gastroenterology, Cairo University, to ask you.
Thank you, Professor Mona. Thank you, Professor Alistair, for your nice talks. I have a small comment. Professor Mona, in your lecture, you are using the term NASH, non-alcoholic.
Yes.
Is it the time now to change this to the newer definition or newer nomenclature, which is the metabolic associated fatty liver disease?
Yes.
Because non-alcoholic is inconclusive and it's a negative diagnosis.
Yes.
What do you mean by non-alcoholic? This does not mean a specific etiology, while metabolic associated fatty liver disease is more informative. What's your opinion?
Okay. Metabolic associated fatty liver disease, I think it is right for the new nomenclature, but Still now in Egypt, we did not measure the highly sensitive C-reactive proteins. So in that aura specifically, we need much more in our patients to tell that they have muffled. A lot of patients have a little concerns from my point of view. It's a little one.